Hello, I'm Manoj Karmakar. Welcome to ISSPS TV. In this next video, Dr. Shahridan Muhammad Fathil from the Gleneagles Hospital in Johor, Malaysia, will be sharing his insights into point-of-care ultrasound of the lung. If you like any of our videos, don't forget to share and hit the like button. And if you're new to this channel, do remember to subscribe so that you can get regular notifications of any future uploads. Now enjoy the upcoming video.
This is the webinar 10 of the ISSPS 2021 series. This is where I work at the moment, Gleneagles Hospital, Medina, Johor, down south of the Peninsula, Malaysia, just slightly north of Singapore, 100-odd bedded hospital with a strong emphasis on oncological services. We do practice point-of-care ultrasound quite extensively in our day-to-day work. I am affiliated with the WIN-Focus Group, World Interactive Network focused on critical ultrasound way back since 2008. I am still currently one of the executive committee members of the local chapter for Malaysia. I am currently receiving support for travel and accommodation to conduct the hands-on demonstration shortly later. So with regards to the aim of this talk, I have about 25 minutes to half an hour. So I think it's probably in the best interest of time to not talk too much on the evidence, particularly with regards to comparison ultrasound versus chest radiograph. But I will talk more on the actual how to actually do lung ultrasound, so that at least particularly for the ones who are new to POCUS can at least take home some of the points and maybe start adopting this ultrasound modality in their clinical practice. I will start with a bit of introduction. The first one of the publications on lung ultrasound was actually by Daniel Lichtenstein, who is the father of lung ultrasound, in his in this 1993 intensive care medicine article. He documented the examination of 150 consecutive patients, of which there are few lung ultrasound. There are 3 cases of empyema and 2 cases of pleural effusion. Subsequently, in 2007, in critical care medicine, the founding fathers of WIN-Focus, Luca Neri, Enrico Stotti, and Daniel Lichtenstein came out with this ABCDE primary assessment of critical ultrasound. So under B, breathing, you can see there is actually lung ultrasound, in which they describe ventilation, emphysema, pneumothorax, pleural fluid, atelectasis, and so on. So this was one of the, actually this was the first actually comprehensive primary assessment of POCUS, but what the WIN-Focus fathers coined as critical ultrasound. Definition of point of care ultrasound, I would like to use this 2011 New England Journal Medicine publication. Point of care is defined as ultrasound brought to the patient and performed by the provider in real time. So technically, in this sentence, there are 2 points here. Brought to the patient, i.e. bedside. The bedside can be in the field, pre-hospital setting, right up to operating theater and the ICU. And the other point is performed by the provider in real time. Point of POCUS is actually performed by the clinicians and not by the diagnosticians. In that particular article, you could see there's only actually 3 applications for anesthesia, which is actually line access, regional anesthesia, and intraoperative monitoring of fluid status and cardiac function, particularly using TEE. But evident by today's webinar, the application has actually expanded quite extensively. The first documentation, intraoperative documentation of the use of lung ultrasound is actually way back in 2011 by Kenichi Ueda, which documented a series of two cases of the diagnosis of pneumothorax, intraoperative pneumothorax with lung ultrasound. And in that particular issue, there was an editorial. I just like to quote a paragraph. If TEE, vascular access, and regional anesthesia represent established mainstream applications of perioperative ultrasound, chest ultrasound, and other modalities have emerged more recently among anesthesiologists. Just to reminisce, in 2012, I delivered a talk in the ISSPS. The title of the talk is actually Forecasting the Trend in the Expanded Role of Point-of-Care Ultrasound in the 21st Century Clinical Practice. I actually highlighted different point-of-care scenarios, and even in that particular talk, I quoted this publication, International Evidence-Based Recommendations for Point-of-Care Lung Ultrasound. So this is a publication where the authors of lung ultrasound articles, 28 of them, led by Giovanni Valpicelli, came together and came out with 70-odd statements or recommendations. And this is one of the most cited article, 1,300 odd, the last I checked, of any intensive care medicine article. And subsequently, in 2017, as far as the regional anesthesia and pain medicine fraternity is concerned, we came out with the first series of POCUS. So this was authored by the second speaker. This was an editorial, and subsequently in 2017 and 2018, we came out with a focused cardiac ultrasound for regional anesthesiologists and pain specialists. There was also a lung ultrasound and then gastric ultrasound. So as I mentioned, I will not basically touch upon the evidence because the evidence is quite strong out there. And in the interest of time, I will emphasize mainly on actually how to actually perform point-of-care lung ultrasound. We can use all probes actually, but the most I would say appropriate, I would say the most used are actually the curvilinear, the low frequency, higher penetration, and as well as the linear probe, particularly if you are interested to examine the pleura. But in the literature, all this have been documented. That has been documented in with regards to lung ultrasound. Particularly, Liechtenstein likes to actually use the microconvex transducer. How do we approach this? Is actually in order to screen, we use a longitudinal scan, so you will see part of the ribs. And if we are actually, when we want to actually zoom in, we turn the probe around to do transverse scan, and you will lose the ribs from the ultrasound images. With regards to topography, this is the topography that's recommended by the consensus article. So basically, you can divide the anterolateral to 1, 2, 3, 4. So this is divided by the anterior axillary line and the posterior axillary line. So for the 5 and 6, For the 5 and 6, it's actually the ultrasound probe needs to actually be at the paraspinal area to actually look at the pathology or behind. So, of course, in ventilated patients, this can be a bit difficult. As evident here, that the patients need to be turned around. There's also recommendations that you dig into the ICU bed, so that at least you, without turning the patient around, you might be able to see some aspects of the lateral part of the posterior lung. Okay, let's look at normal lung. So we know normal lung has got more air rather than fluid. So let's start with the longitudinal approach. So this is what you ought to see. This is, some would say this is actually the bed sign, technically the head of the bed, and the shadow of the ribs form the actual wing of the beds, the wings of the beds. So this is the pleural line, and you can see this is sliding. Okay, so what it means is that what you are seeing now is actually the sliding of the visceral and rubbing onto the pleural, onto the parietal pleura. And you can see this, the blue arrow indicates the pleural line, and there are actually reverberations underneath it, which is actually what we call A lines. So this reverberations is generated because there is actually reflections, reverberations of the ultrasound beam from the chest wall. So there's reflection, and there's actually returning back of the ultrasound beam from the chest wall back to the pleura, and it bounces. Some of it is returned back to the probe. So what the machine senses is that there are actually multiple pleural lines. So generating what we call this equidistant lines as A lines. So these are actually normal physiological findings in the lung. Okay, we ought to understand what we can see in the basis. So if we put our probe in the mid-axillary line on the right side, and we scan capsular, this is what we're going to see. This is actually a fast view. We will see the liver and the kidney, and this is the Morrison spot about it, and the hyperechoic diaphragm. And can you see this sliding pleura? And some authors use the word curtain sign, as if the curtain is being drawn in and out. So this is normal. It's important to appreciate the liver or the solid organ and the diaphragm, because you may see consolidation or hypertization of the lung, and you want to know what you need to confirm whether it is actually in the peritoneum or in the thorax. So hence the need to actually identify the solid organs of the peritoneum on the right side. And if you move on the left side, so the probe is usually placed a bit more posterior as compared to the right, which is the right, usually around the mid-axillary line is enough, adequate. So this is what we ought to see. The spleen, the solid organ, kidney, and this is the splenorenal recess, and the diaphragm, and again, the curtain sign, sliding sign of the pleura, appearing as if the curtain is being drawn in and out. So this is normal physiological ultrasound findings. Okay, what are abnormal findings? So with regards to pathology, I'm just going to emphasize on the acute changes of 4 main pathologies: pleuroeffusion, pyremedema, pneumonia, and pneumothorax. Let's look at effusion. So again, effusion is fluid, and fluid will collect at the dependent area of the thorax. So this is actually the spleen, looking at the spleen, and the kidney, and you could see this is an echoic area, which is actually the thorax being filled with fluid. There's another sign here, what we call a spine sign, which normally we don't see in normal aerated lung. This is actually, the spine can be seen clearly through effusion. Another view image of infusion. This is actually the lung being compressed and becoming atelectatic. You see again the diaphragm here, hyperechoic, and this is part of the lung, atelectatic lung. Another entity that we should know is actually interstitial syndrome. So technically, it's because of the thickening of the interlobar septa in the interstitium. And this happens mainly in pulmonedema as well as in contusion, early parts or early phases of the infective pneumonic process. It is an entity, and usually on lung ultrasound, it appears as what we call B lines. So these B lines appear from the pleura, and it goes way down to the bottom of the screen, and it actually moves with the pleura. So whereas compared to the A lines, again, these are A lines, which is actually reverberations, or actually as if there are multiple pleural lines down beneath the deep to the pleura. So with regards to the pathology, to the pathogenesis of these B lines, it's a bit unclear, but it is thought that it's because of reverberations of the ultrasound beam being bound, reflecting on the thickened interlobar septa. But again, the actual pathology at the moment is still not well understood. So the differential diagnosis can be pulmonedema, pneumonia, contusion, and ARDS. In pulmonedema, it's the B lines can be extensive. It's generalized all over, particularly more so in the dependent area. Okay, this is what you can see in the non-dependent area. It's going to be B lines, and in the dependent area, there may be actually effusions. Okay, if you could see that it's actually the B lines, it's actually coalesced, it's actually quite thick, and it's initially numerous and quite thick and becomes coalescent. So this indicates that actually the pulmonedema is actually quite severe, and you could use this actually to direct the therapy. So the therapy can actually, the lung ultrasound can actually indicate whether the therapy is successful or not by the changes in the numbers, in the thickness of the B lines, as well as in the numbers of B line. Pneumonia. So what happened with in the lung is actually this, what we call another name for it is alveolar syndrome. That's actually filling up of the alveoli with either exudates or other proteinaceous fluid. So what appears is actually something like this. There's a bit more signal coming down from the lung parenchyma. There's actually distinct borders down here, and what appears as actually some authors would call this shred sign. So technically, it's like a paper, and it's being torn a bit, and this is the actual border of the paper that has been torn away. Another point to actually suggest pneumonia or consolidation is actually this. Can you see this movement? This is hyperechoic movement. It's actually air bronchogram. So the air is being seen here, documented on ultrasound. It's moving in the bronchus. In the extreme, this is what you see, because there is actually a filling of the alveoli, and the lung actually becomes hepatized, hence the name hepatization on lung ultrasound. And you could see these are actually bronchograms. Some of it is fluid, and when you see this white hyperechoic line going across, it's actually air bronchograms. So this is something similar to what we find on chest radiographs when the pneumonia can present with air bronchograms. The difference between true consolidation and atelectasis can be found, of course, by actually looking at, for example, air bronchograms, as well as the vascularity of the consolidation. And in this particular example of atelectasis, you can't see actually much of the air bronchogram. Another, I would say, important use of lung ultrasound is to differentiate between effusion and consolidation. So you could see that there is significant effusion here, and whereas this is a pneumonia, a consolidation, and there is actually a small pleural effusion on the side. This patient, if these two patients present with in extremis, we know that the one on the left would definitely benefit from pleural drainage, and this may not benefit. In fact, by doing a thoracocentesis, we may actually do more harm, because there's actually a small effusion here, and the thoracocentesis needle may actually hit the lung parenchyma. Okay, with regards to pneumothorax, there's actually this flow that's published in the consensus recommendation. So there are a few, I would say, signs that will actually rule out pneumothorax. When you have lung sliding, definitely there is no pneumothorax. When there's B lines, there's no pneumothorax, because the B line is generated by the visceral pleura. When there is actually a collection of air between the visceral and parietal pleura, you will not see any, you can never see B lines. And this is important, 2 points, two signs, the lung point and lung pulse, which I allude to shortly. Okay, so can you see part of the screen is actually there's lung sliding, and on the left there's no lung sliding. So this is what you will see if you put the probe from anterior to posterior, from the non-dependent to dependent, and you will, at this particular point, when there is the lung and the pneumothorax sort of meeting together, meeting each other, and this is what you will see. This is a point where there's a pneumothorax, and this is where the lung is sliding. So at this point, with lung point, you can say that there is 100% pneumothorax, and the more posterior or the more dependent the lung point is, the bigger the pneumothorax is. So there is a entity called radio-occult pneumothorax, where you don't see it on chest radiograph, but usually you find it a bit more anterior, the lung point, and because of the fact it's a small pneumothorax, you will probably not see the pneumothorax on chest radiograph. Another sign that rule out pneumothorax is actually lung pulse. So this is technically cardiac pulsation being transmitted to the pleura. This is just to indicate the content of the lung from air right up to effusion, and you could see the different signs that is actually being picked up with lung ultrasound with the different ratios. Then Liechtenstein also proposed a protocol, a blue protocol, bedside, I'll say, lung ultrasound examination. So you can diagnose pulmonary edema, pneumonia, pneumothorax, as mentioned, as well as pulmonary embolism. Pulmonary embolism technically is when you have a near normal, or say normal, A profile, the lung, in the patients who is presenting with respiratory distress, and if we perform a compression sonography on the deep veins, if there is a positive compression sonography suggesting a DVT, so a diagnosis of pulmonary embolism is quite likely. This is actually a purist protocol. There's no incorporation of other ultrasound modalities, but in most situations when we are suspecting a pulmonary embolism, we will do a focus echo. With regards to the usage for, quickly a few slides, usage of lung ultrasound in COVID. Recently, we are there's this new variant, the Omicron variant, being documented coming out from South Africa. One of the signs that we frequently see in COVID pneumonia is actually what subpleural consolidation, and the usage can be varied. For example, in the emergency department, it can be used as a triage tool because access, particularly in the case of such capacity, there are access to chest radiograph may be limited. So while doing lung ultrasound, patients can be actually discharged earlier. In the intensive care unit, we can use lung ultrasound to actually guide us in the mechanical ventilation, which I will allude to in a short while. So these are actually the different lung ultrasound findings in comparison to the CT scan. This is the extreme where you have the ARD, near typical ARDS picture when the lung is hepatized, and when you could see somewhere here where there is actually quite small peripheral consolidations, you will see more B lines as well as subpleural consolidation. Just like to quote this particular article, and our final speaker is one of the authors in this Focus for COVID consensus article. So what the author suggested is that we can use lung ultrasound to actually, for example, identify the phenotypes of the COVID pneumonia. The H phenotype with a typical ARDS picture may actually warrant a higher PEEP, and also may actually predict those who respond to the prone ventilation. So what lies in the future? We know now we need to incorporate insonation as part of our physical examination, as suggested by the JAMA article. Now most of the machines will have automated calculation of B lines. So, but this is just an article to highlight that actually they have actually studied that the AI, the artificial intelligence of the machine, can be as good as actually novice practitioners. This is actually just to highlight an example. This is a mind ray slide where with the smart B line features, the machine can actually calculate the number of B lines as well as and give a lung ultrasound score by actually accumulating all the scoring of the different topography of the lungs. So I think in short, it is time for us to actually embrace lung ultrasound. And I think instead of just auscultation, I think in most situations we probably don't do much auscultation nowadays. Definitely insonation is actually a way to go forward. Thank you very much.